Folate deficiency produces exactly the same hematologic and morphologic picture as B12 deficiency: pancytopenia, oval macrocytosis, hypersegmented neutrophils, and bone marrow megaloblastic hyperplasia. From the laboratory's perspective, looking at the blood smear and bone marrow, you cannot distinguish it from B12 deficiency. But there is one profoundly important clinical difference. Folate deficiency does not cause neurological abnormalities. There is no subacute combined degeneration of the spinal cord, no ataxia, no Babinski sign, no loss of vibration or position sensation. The nervous system is spared entirely. This is the single most important clinical distinction between the two deficiency states, and it has enormous therapeutic implications that we will return to. Now let us work through the various causes of folate deficiency with the same mechanistic clarity we applied to B12 deficiency. Severe dietary deprivation is the most common cause of folate deficiency, and it is especially prevalent in chronic alcoholics. Alcohol has multiple nutritionally damaging effects. It suppresses appetite, displaces nutritious food from the diet, and has direct toxic effects on intestinal folate absorption and hepatic folate metabolism. People on extreme fad diets are similarly at risk if those diets exclude folate-rich foods such as leafy green vegetables and legumes. Pregnancy creates a dramatically increased folate demand. The developing fetus requires substantial folate for its own rapid cell division and DNA synthesis. This demand is placed on the mother's folate stores and dietary intake. If a woman's baseline diet provides only marginal folate, just enough for herself under normal circumstances, the additional fetal demand can tip her into deficiency. This is why folic acid supplementation is routinely recommended during pregnancy. Phenytoin, the anti-epileptic drug also known as Dilantin, specifically interferes with folate absorption from the gastrointestinal tract. Even if a person on phenytoin is consuming adequate dietary folate, impaired absorption means less of it reaches the circulation, creating a functionally deficient state over time. Oral contraceptive therapy also interferes with folate metabolism through mechanisms related to estrogen effects on folate transport and metabolism, producing a similar risk of deficiency in susceptible individuals. Folic acid antagonist chemotherapy drugs, the classic example being methotrexate, work by deliberately blocking dihydrofolate reductase, an enzyme that is critical in the folate metabolic pathway. This blockade prevents cancer cells from accessing folate for DNA synthesis, which is the therapeutic intent since cancer cells are rapidly dividing. However, the same blockade affects all rapidly dividing cells in the body, including normal hematopoietic cells in the bone marrow, producing iatrogenic megaloblastic anemia as a predictable side effect. We will continue in the next video.